Clinically, thrombocytopenia is defined by a strict threshold, a platelet count dropping below 100,000 per microliter of blood. In these patients, the bleeding time is prolonged, yet the prothrombin time and partial thromboplastin time, the major coagulation pathways, remain entirely normal. A patient presents with widespread petechiae and mucosal bleeding. Tests confirm the platelet count is critically low, but the coagulation cascade is functioning perfectly. Clinicians must determine if this deficit originates in the marrow factory or if the platelets are being consumed in the peripheral circulation. The first category of causes involves decreased production, or central failure. Here, generalized diseases compromise the bone marrow's megakaryocytes, choking off the supply line at its source. The second category is decreased survival, or peripheral destruction. The marrow is fully operational, manufacturing platelets at a normal or even accelerated rate, but immunological or non-immunological forces destroy them as soon as they enter the bloodstream. Differentiating these two mechanisms, the broken factory versus the hostile transit, is the mandatory first step in the pathological workup of any bleeding patient. To understand central failure, we evaluate aplastic anemia as our primary clinical model. The pathophysiology here is direct. The syndrome is driven by primary defects in, or outright damage to, the hematopoietic stem cells and the bone marrow microenvironment that supports them. Stem cell damage results in peripheral pancytopenia, a simultaneous drop in all three major blood cell lines that leaves the marrow cavity functionally empty. This pancytopenia maps directly to the patient's clinical triad. The lack of red blood cells causes severe anemia, resulting in pallor and fatigue. The lack of platelets causes thrombocytopenia, leading to petechial rashes. Finally, the depletion of white blood cells causes neutropenia, which manifests as overt recurrent infections. Over 80% of aplastic anemia cases are acquired. The triggers for these acquired cases include autoimmune diseases, severe nutritional deficiencies in B12 or folate, toxic exposures to chemicals like benzene, adverse reactions to drugs such as chloramphenicol, or infections from hepatitis, Epstein-Barr, and HIV. The remaining minority of cases result from congenital or inherited diseases that intrinsically limit marrow function. Fanconi anemia is an autosomal recessive disorder that accounts for many of these cases. It presents with multiple congenital anomalies, most notably short stature and physical malformations of the thumbs and radii. Another inherited cause is dyskeratosis congenita, identified by a highly specific physical triad: dysplastic nails, a lacy reticular pigmentation across the upper torso, and oral leukoplakia. Whether acquired or inherited, the definitive diagnosis requires extracting tissue. A bone marrow aspiration and biopsy must reveal profound marrow hypoplasia to confirm the system has shut down. Without intervention, the patient will succumb to hemorrhage or infection. Management requires immediate blood transfusions, intense immunosuppressive therapy, and ultimately hematopoietic cell transplantation to replace the dead tissue. Aplastic anemia is a total systemic collapse of blood manufacturing that requires a complete reset of the factory. To evaluate the opposite mechanism, peripheral destruction, we have to examine the microscopic machinery that makes a platelet function, which simultaneously makes it a target. Platelets are not true cells. They lack a nucleus.
They are membrane-bound, smooth discs acting as precise delivery vehicles for specific chemical payloads. This electron micrograph reveals the extreme internal density of a platelet, showing heavy internal granulation, marked GL, contained within strict microtubule boundaries, marked MT.
Mapping this out in an ultrastructure diagram, we identified two primary storage vessels: scattered, darker, dense granules, and more numerous alpha granules. Alpha granules hold von Willebrand factor and fibronectin. Dense granules contain ADP, serotonin, and calcium. Upon activation, these are expelled through the open canalicular system. These payloads dictate the three functional phases of hemostasis: adhesion, secretion, and aggregation. This diagram outlines adhesion. Look at the unstimulated platelet. The membrane is embedded with specific glycoprotein hardware, notably inactive IBIX and IB2B receptors. When a vessel tears, von Willebrand factor acts as a bridge, linking the exposed subendothelial matrix to the glycoprotein IBIX receptor. This binding initiates secretion. Intracellular phosphorylation triggers the release of ADP and calcium into the blood. Finally, aggregation begins. Secreted ADP and synthesized thromboxane A2 activate IB/3A receptors to cross-link with circulating fibrinogen, forming the primary hemostatic plug. These surface glycoproteins, IB/3A and IB/9, are highly specialized tools for clotting, but their unique physical structures are the exact vulnerabilities exploited by autoimmune disorders. Idiopathic thrombocytopenic purpura, or ITP, serves as the primary clinical model for autoimmune peripheral destruction. Chronic ITP most frequently affects adult females between the ages of 20 and 40, often occurring in isolation or alongside other autoimmune diseases. The pathology occurs because the patient's immune system produces rogue IgG antibodies directed explicitly against the platelet membrane glycoproteins, IB/3A or IB/9. The spleen is the major site of antibody production. It is also the site where the immune system's macrophages identify these IgG-coated platelets, engulf them, and remove them from circulation entirely. Because the destruction happens in the periphery, the bone marrow profile in an ITP patient looks completely different than the empty void of aplastic anemia. The bone marrow factory shifts into overdrive. The marrow space fills with massive, hyperactive megakaryocytes, shedding fragments as fast as possible to replace the stock being consumed in the spleen. A second, distinctly dangerous model of peripheral destruction is heparin-induced thrombocytopenia, or HIT. HIT develops in roughly 3 to 5% of patients treated with unfractionated heparin, typically presenting 1 to 2 weeks into therapy. In HIT, the antibodies do not target the intrinsic surface receptors. Instead, IgG antibodies target new molecular complexes formed when heparin binds with platelet factor 4. Rather than flagging the platelet for splenic removal, antibody binding here triggers violent systemic platelet activation and aggregation. This mass activation exacerbates massive arterial and venous thrombosis. The patient develops life-threatening clots, leading to limb loss or death, despite having severe systemic thrombocytopenia. The only viable treatment is the immediate and absolute cessation of all heparin to break the cycle of activation and consumption. While ITP depletes platelets through quiet consumption in the spleen, HIT depletes them through forced systemic clotting. This diagnostic framework organizes our findings across marrow cellularity and primary clinical risk. In aplastic anemia, central failure results in an empty hypoplastic marrow, yielding pancytopenia. The threat is a trifold risk of bleeding, profound anemia, and sepsis. In ITP, autoimmune destruction in the periphery causes a hyperactive marrow with increased megakaryocytes. The threat is isolated thrombocytopenia causing mucosal bleeding. In HIT, drug-induced antibodies force platelet activation. The primary threat is paradoxical, life-threatening thrombosis. A low platelet count on a lab report is merely a symptom. Treating the patient effectively requires deducing the exact structural mechanism of failure.